So without any further delay, we are going to start our inaugural first scientific session. I would like to introduce our panelists of this session. Dr. Waqash Shafiq, if you are here, sir, please join us on stage. Professor Khurshid Ahmed Khan, sir, please come on stage and join us for the scientific sessions. The first talk will be from Professor Dr. Randawa, CH in Infertility, Options, Expectation and Outcomes. We are really looking forward to your contributions, questions and discussion, but please scan the Slido software and put your question there, and that will be then selected by the panelist and answered by the speaker. So let's begin the scientific session. Sir, please come on stage and continue your talk.
Bismillahirrahmanirrahim. Thank you, Tahir, for inviting me. Or we will start the session. I will try to be as focused as possible. Dr. Osama ने एक मुझे टेक्निक बताई तो थी एक चीज़ बताने के लिए, लेकिन वो ज़रूरत पड़ी तो मैं आखिर में आपको करूँगा. We will start it. We will stick it to fertility, and hopefully we will finish in time. Fertility in CH patients depends upon the severity. Actually, it depends upon the communication and the way the patient presents, starting from non-classical CH to non-classical CH and PCOS, and the fertility is directly proportional to the CH fertility. And you can see from 90% to non-classical CH, which can conceive even without intervention, to interventions depending upon which enzyme is deficient. These are basically the pathophysiology with which the females presents in CH who are infertile. They are all pretty much self-explanatory, starting from anatomical problems to hormonal problems, and one or two pathophysiology for each problem will be discussed. Like you can see anatomical problem starts from virilization of external genitalia to the small anatomical problems which can lead to the infertility, which needs to be negated by the surgery before the patient gets into adult age in order to get fertility perspectives. This is the disruption of hypothalamic pituitary ovarian axis. Basically, it's excess androgens, and all the androgens actually boils down to the problems which leads to the depressed. You can see that elevated androgens are aromatized to estrogens, which will then take control, and that suppresses the gonadotropin secretions, which can lead to fertility. GnRH pulse generator is also affected, and so is the elevated androgens can directly inhibit follicogenesis. So they are actually polyfactorial, multifactorial. Every patient responds differently. You have to investigate depending upon the pathology. As far as ovarian effects are concerned, the adrenal androgens actually inhibits follicogenesis, and they suppresses the aromatase activity in the granulosa cell, which leads to sometimes ovarian adrenal rest syndromes. So this is one of the factors, and it is one of the most important factor, because this is the indicator which we have to monitor. Progesterone is actually releasing continuously and persistently, which can lead to either of the pathophysiology, which can lead to the infertility, which will lead to GnRH pulse frequency alteration, reduced tubal motility, and disruption of endometrial development along with cervical mucus thickening. So we have to negate this pathophysiology if we want to make the patient fertile. So preconception genetic counseling for all adults is of paramount importance. As you can see, the patient should understand whether the patient has got CH, which type of CH, what could be the percentage of contraction of this CH to the baby. So this has to be negated, especially and ideally preconception. And these are the prerequisites for females to get fertile. We have to normalize menstrual functions. But interestingly, both the treatment, if you are under-treating or over-treating the patients with glucocorticoids, the menstrual irregularities will be there. So there's a thin line. So the goal of therapy will be follicular phase progesterone levels of less than 0.6, which can be achieved, sometimes very difficult to achieve, which will be discussed later. And the corticosteroid dosage will accordingly be managed and should be increased to further suppress the progesterone. And the active functional anatomy, as I said, initially the anatomical factors should be negated, ideally in the adolescent age. So the patient requires reconstructive surgeries and sometimes multiple surgeries. So every patient responds differently depending upon the severity of anatomical defect which a patient is facing. This is the most important slide. what you should know is, अगर आपके पास ऑप्शन है, हाइड्रोकॉर्टिसोन इज द गो टू मेडिसिन, इसके अलावा कुछ सोचे ही ना कोई मेडिसिन. बट द प्रॉब्लम हेयर इज मोस्ट ऑफ द टाइम हाइड्रोकॉर्टिसोन इज नॉट अवेलेबल. सो द सेकेंड मोस्ट कॉमन मेडिसिन शुड बी प्रिस्क्राइब, विच इज prednisolone, which is readily available. The most interesting thing is combined regimes. Combined regimes are mostly not required, but sometimes if you are not achieving the adequate response with hydrocortisone, you start off with hydrocortisone in the morning and you give a night dose of a prednisolone, of a long-acting hydrocortisone, steroid, either prednisolone or methylprednisolone, which is not available in oral form in Pakistan. So combined regimes are sometimes required. And the last but not the least, most important aspect, which is very controversial, is about dexamethasone. The research is very controversial regarding the results of dexamethasone. Most of the patients are not receiving it, and the researchers are not preferring it, except in those patients who are being treated for TART. So dexamethasone is the most important problem, which is basically transplacental transfer ho jata hai dexamethasone ka, and dexamethasone can affect the fetal, if they can control the hyperandrogenism, but they can affect the growth of the fetus, because is the only steroid which can be transferred through placenta. Fludrocortisone is required as in adrenal crisis, so it depends upon, sometimes hydrocortisone is more than enough and you might not be requiring fludrocortisone, but depending upon the patient's response, fludrocortisone at that same dose of 0.05 to 0.2 milligram per day, always once a day, should be given to the people who requires it despite the adequate replacement of hydrocortisone. And interestingly, there are some refractory cases, and this is the recent one. So adrenalectomy can be offered, but it is not free of side effects. You can have adrenal rest tumors in ovaries because of the uninterrupted stimulation from ACTH, and risk of Nelson is always there. And ovulation induction is required most of the time in patients who are on glucocorticoids, still not ovulating, and all the formal treatments which we are actually receiving for PCOS and other causes could be tried. And this is crinecerfont, which is only available in USA, and it is being registered for patients and research. And this is basically CRF1 receptor antagonist, and it is being used only for CH. It is being approved, and it actually is used to combat the side effect of steroids, to combat all the patients who are at risk of developing the steroid side effect. Crinecerfont should be as an adjunct medicine, and it is given 100 milligram twice a day. And as far as I am discussing fertility, so infertility is category B, so that's why I put this slide. You can give it in crinecerfont, but still it is long way to go. It is not available here. And before I go, male infertility is caused by this pathophysiology, and most important aspect of this is testicular adrenal rest tumors, which are not uncommon, and because of the fact that ectopic adrenal cortex remnants are there in testes, which are under the effect of ACTH, and they can cause testicular adrenal rest syndromes, and they can cause mechanical as well as hormonal obstruction, which can cause infertility in males. So they should be treated. And suppressed LS-FSH due to adrenal progestogen and adrenal excess is one of the main pathophysiology of infertility. And lastly, oligospermia and azoospermia is there, which is treatable because TART actually causes the decrease in the quality as well as quantity of sperms. So these are the management options for males. Glucocorticoid remains the mainstay of treatment in the similar way as of female. Hydrocortisone is preferred medicine, and all the others will follow depending upon the situation. Sperm retrieval should be offered because it is now doable in Pakistan, though it is not cost effective, but it is most of the time you will be needing it if the patient is not been adequately treated. Gonadotropin therapy, if the patient has low LH-FSH, surveillance is of prime importance because there is TART is not uncommon, and you have to negate TART by doing annual testicular ultrasound by default. And lastly, cryopreservation is there, and it is available in Pakistan, and TART patients may progress because of the TART, and TART is not so uncommon. So always counsel the patient, though it is not cost effective, but your patient should know the options of fertility regarding the management of CH in males. Thank you.
Yeah, I will invite the next speaker who's going to give us talk on adult growth hormone deficiency and overlooked endocrine disorder in adult medicine, Dr. Osama Ishtiaq.
Thank you. Bismillahirrahmanirrahim. Assalamu alaikum everybody, and thank you, Dr. Tahir, for this talk. Although uh, many gods, and you gave it on my own. Okay. So in next 20 minutes and some extra bonus of 5 minutes, I'll be talking about the adult growth hormone deficiency. No disclosures, and so topic to be discussed. And I hope I'll be able to do justice about this important topic. Although we rarely think about it and rarely treat patients in our clinical practice. I'll be talking about the presentation types, transitioning, especially few slides regarding transitioning of childhood growth hormone deficiency into adulthood, then how to diagnose and the kind of treatment available and what are the treatment benefits and what other aspects regarding to the adult growth hormone deficiency basically. So we've been treating and we all know much about childhood growth hormone deficiency. You all know that when you treat childhood growth hormone deficiency, the patient tend to increase height, gain height, build adequate stature. But what about the growth hormone deficiency in adults? Because in adults, height is already been established. So there are some other factors why this hormone is important in adults as well. So if you go for with age, the secretion of the growth hormone is not similar throughout the age. In the last ages, especially from 50 onwards, the level decreases over the with age. What we call it as somatopause. So in this is the area where it's very difficult to assess whether this patient has a growth hormone deficiency or a physiological depletion of growth hormone with age. In younger ages, you have a reasonable levels of growth hormone, so diagnosis would be easy over here, but trickier in the later ages. So what is actually adult growth hormone deficiency? Is basically one of the syndrome affecting a lot of patients, but it's not a very common entity. Why it's important? It's important because it's associated with mortality and morbidity. And if you treat a growth hormone with growth hormone, and you have seen a lot of cardiovascular benefits along with improvement in the quality of life as well. I'm coming to it that regarding how the benefits actually are there with the treatment of growth hormone. So there can be the patient can present as primary as adult onset growth hormone deficiency or the continuation of childhood growth hormone deficiency. There is a transition of care from childhood to the adult basically. And sometimes you need to, well, most of the time you need to retest the patient who are actually on growth hormone during their childhood phase. When they are actually going into adulthood phase, you need to retest them to see whether they need growth hormone in adult as well or not. So common causes in childhood are basically radiopathic, followed by a lot of CNS pituitary tumors, including craniofaryngoma. We have a lot of patients we have having unknown cause of growth hormone deficiency. Why the adult growth hormone is so much important, deficiency is so much important. Why the literature has shown that with the deficiency, there is decreased lean body mass, decrease in the bone mineral density, leading to osteopenia, osteoporosis, decreased physical performance, decreased cardiac activities, and increased central fat depositions, sometimes glucose intolerance, dyslipidemias, and psychological aspects, especially impaired cognition, poor memory, depression, mental fatigues, and the reduced quality of life and low self-esteem. So these are the different features of adult growth hormone. They are not that much specific because we have seen a lot of similar disorder in other disorders as well. Why growth hormone deficiency is important in terms of cardiovascular mortality and morbidity? It has a lot of various effects, especially visceral obesity, insulin resistance, dyslipidemias, all these factors actually lead to atherosclerosis and later on development of cardiovascular disease. But this area needs a more and more research and whether treating this deficiency improves cardiovascular health or not. So this is another view representation of growth hormone deficiency in adults. When if you treat with growth hormone, you have, the literature has shown there is a definite improvement in cognitive function, cholesterol, cardiac activities, and especially the bony health, and improvement in the muscle mass and the strength, and some harmful effects in terms of if the patient has diabetes and if you give a growth hormone on top of it, it can sometimes cause worsening of diabetes as well. It's not common, 2 to 3 in 10,000 of population. In our part of the world, we don't have enough data regarding the prevalence, but we do see some patients I, in my clinic, have some patients, we can count them on fingers, but there are some patients who have actually adult onset growth hormone deficiency as well. So you can give them a treatment option, especially those who do not actually feel well, despite adequate treatment. So a few slides regarding transition period. What a transition period is a set of physical changes that start late in the puberty and end with full adult maturation, usually from mid to late teens and until the achievement of final height. Why it's important? Because a lot of patients who have a growth hormone deficiency in childhood possibly need a continuation of growth hormone treatment in adulthood as well. Why? Because if you stop early, once the height is achieved, the literature has shown that later on they develop low bone mineral density, impaired bone microstructures, and some structural abnormalities, and can cause the development of early osteoporosis as well. So you need to assess whether this patient being treated on growth hormone, whether the patient needs growth hormone in adulthood as well or not. So how would you proceed? Basically, this is a rather busy slide, but try to make it simpler. If the patient has been diagnosed with, growth hormone deficiency in childhood, what are your actually the flow actually? Once the patient has achieved adequate growth in puberty, you stop the growth hormone at least more than a month, 1 or 2 months, and then reassess the patient regarding the growth hormone deficiency. There can be two possibilities. Patient has a highly likelihood of growth hormone deficiency, like a patient having a craniopharyngioma or a pituitary abnormalities. The chances of growth hormone deficiency are much higher. In that case, you need to monitor their serum IGF-1. And if that comes below -2 standard deviation, the diagnosis is confirmed. You don't need a dynamic test over here, basically. But if the level comes above 2 standard deviation, then you need to go for an additional test, what we call as a growth hormone stimulation test. If the stimulation test, what you prefer, if you prefer ITT, you need to see a definite peak growth hormone cutoff point. If that level comes low, then the diagnosis is confirmed and you need to restart the growth hormone in that case. If that turns to be normal, then you need to reconsider your diagnosis that the patient is possibly has cured of growth hormone deficiency. If there is a less likelihood of growth hormone deficiency, especially in idiopathic growth hormone deficiency cases, because literature has shown that in idiopathic cases, the patient actually tend to develop normalization of growth hormone secretion after the puberty, basically. In that case, you need to retest. You need to go for both tests, especially the growth hormone stimulation test along with IGF-1, and then assess according to the results, basically. If both come low, then you have the option to restart the growth hormone. If the tests are discounted or they're both normal, you can discharge the patient, or you can reassess after a year to see whether this patient needs growth hormone treatment or not. Basically, the recommendations are to restart the growth hormone are around lesser than 50% of the dose the patient was taking in the childhood, and then you monitor accordingly 6 monthly early and adjust the dose to keep the IGF-1 around 2 standard deviation, below the 2 standard deviation. Maximum, don't go beyond it actually. And then reassess height, weight, BMI, waist circumference, BMDs, and other parameters, metabolic parameters, and reassess whether the patient needs continuation of treatment. Usually, up to 24 or to 25 to 30 years, the treatment is needed, and then you need and then reassess whether the patient needs continuation or not, especially for the bones. Etiology, the commonest cause in adults is basically pituitary abnormalities, craniophryngiomas. We see a lot of pituitary tumors who are actually given radiotherapies, who have been treated with surgeries. They tend to develop growth hormone deficiency as well. So these are the most commonest causes we see in our clinical practice. There are some other causes like traumatic brain injury sometimes, and few cases regarding subarachnoid hemorrhage has been seen to develop adult growth hormone deficiency as well. Sheehan syndrome, hypopituitarism is another aspect. We treat them with steroids, thyroxines, and granted male or female hormones, but we tend to ignore growth hormone deficiencies. But in this case, you need to think about this patient may be needing growth hormone treatment later in the life as well. So when you go for, when you have a pituitary tumor, this is one of the mass effect of pituitary tumor. The growth hormone is the first hormone to lose actually. followed by LHFSH, and then at the end you have a TSH and the ACTH. So growth hormone is a very sensitive hormone, especially in patients who have a pituitary tumors. So whether all patient needs testing or not, that's a question. That's a debatable question. If you have a plan to test growth hormone deficiency, and if the patient is willing to get treatment after the test results, then you go for a testing. Avoid testing in those patients who are not willing for basically treatment with growth hormone. Because we all know that growth hormone is an injectable preparation. You have to take it daily. So far, the available preparation in our country. So the question needed to ask regarding who should be tested. Not everybody should be tested. And when and what test you have so far to test, and whether there is a similar criteria for every patient or not, or you have any influence of BMI on these tests or not. The guidelines show say that if you are planning or if you are suspecting for adult growth hormone deficiency, you can test there and then. But need to keep in mind if the patient has a pituitary problem, all patients should be given hormones adequately, and in coming follow-ups, you need to ask the patient repeatedly whether they are feeling normal or not. If they think they are not feeling normal despite adequate treatment with steroids, thyroxine, and androgens or female hormones, then you could think about whether this patient needs testing for growth hormone deficiency or not. Especially an adequate treatment given still the patient having fatigue, changes in body fat, muscle or bones, then there is a point, there is a level at which you can plan to go for a testing. But in cases where there is no suggestive clinical history, evaluation of adult growth hormone should not be performed. So how would you go for the evaluation basically? There can be organic cause, like the patient has more than 3 hormonal deficiencies, the chances of adult growth hormone deficiency is much higher. You go for a IGF-1 level straight away. If it comes below -2 standard deviation, no further testing is required. The patient needs treatment there and then. If there's an organic growth hormone deficiency, a suspicion, if patient has a 1 or 2 hormonal deficiencies with a low IGF-1, this patient needs a further testing, especially with the dynamic tests. If the patient has hypothalamic pituitary disorders, surgical apoplexies, empty cellars, traumatic brain injuries, Seon syndrome, autoimmune hypophysitis, then you think about whether this patient has a suspicion of adult growth hormone deficiency or not. If there is a high suspicion that the patient has a low IGF-1, usually below 0 SDS, then you don't need to treat there and then. You need to some additional tests, especially the growth hormone stimulation test, to classify this patient as having a growth hormone deficient. So further the test involving the growth hormone deficiencies, there are a variety of tests. Remember, random growth hormone or random IGF-1 level, the A suggests the random IGF-1 level also should not be used alone to diagnose growth hormone deficiency in adults. Especially in those patients when there is no clear-cut evidence of pituitary hormone abnormalities. Like if the patient already has 3 hormonal abnormalities, there is a chances of growth hormone deficiency is much higher in this case, but not in everybody. So you need to establish the diagnosis with a dynamic test basically, and another test. So we have in our country what we can offer to the patient, we have ITT. The cutoff in these patients is usually 5. The 5 level of growth hormone is usually almost 95% sensitive. If the patient has a level above 5 after ITT, you can safely say this patient does not have actually the growth hormone deficiency basically. There are other tests available, not commonly performed. We don't have these things. L-DOPA is not a sensitive specific test, should not be performed, especially in adults. Glucagon stimulation test, not available in Pakistan. And Morelin basically is quite costly, it's not available. It's quite tolerable, safe, very simple and speedy test in terms of growth hormone deficiency. But ITT is a gold standard one. A lot of contraindication risk involved with ITT, and sometimes it's very difficult to perform. A patient needs admission, is a costly test, not set up as well. But it's so far considered as a gold standard. Glucagon, the level of growth hormone basically is dependent on the BMI of the patients. If the BMI is usually less than 30, a level below 3 is reasonably well. If the level is less than 3, you can safely say this patient has a growth hormone deficiency. If the BMI is above 30 or more than 35, usually a cutoff point of 1 is taken as significant in these cases. It's quite a reasonably good test. It has a reasonably good sensitivity and specificity. Mastimorelin is basically a ghrelin GS1R1A receptor, and it's an FDA approved in 2017, and it's also a reasonably good test. It's fast, speedy test having a limited side effects. But unfortunately, that's not available, and it's quite costly in US as well. So not all patient needs dynamic testing. I've told you earlier, because the dynamic tests are not easy to perform. If the patient has a number of pituitary hormone deficiencies, the chances of growth hormone deficiency are much higher. In this, you can see in this graph, you can see if the patient has 3 or more hormonal deficiencies, the chances of growth hormone deficiency is much higher compared to those patients who have a very limited other pituitary hormonal deficiencies. Possibly you need a dynamic test in this group basically. The criteria I've told you earlier, ITT is less than 5 basically. Glucagon is usually dependent on the BMI. Mastimorelin is also 5, and these are the usually cutoffs being used basically. So what are the treatment options? Just going to the treatment, basically this is a clinical historical milestones. In mid-1980s, recombinant human hormone was actually produced, and since 1980s, we have a recombinant human growth hormone. Previously, we have actually human purified carabar pituitary hormone having a lot of problems. Why growth hormone is given, and what are the literature so far? There are several meta-analysis studies have shown reasonably good results of growth hormone treatment in patients who have a growth hormone deficiency. You can see it improves fat mass. It has a limited effect on BMI, triglyceride, but has reasonably good effect on LDL, cholesterol, diastolic blood pressures. But unfortunately, with the cost of worsening of insulin resistance and worsening of glucose urea as well. So in these cases, you need to keep in mind, if you are giving growth hormone to these patients, especially diabetics or patients having insulin resistance, you start with a very low dose, and then you need to adjust their diabetic medication so they don't develop hyperglycemia. Regarding the bone health is well established. If you go treatment for 2 years or more, the number spine Z scores, Feynman leg Z scores, and Watts triangle Z scores are remarkably increased with growth hormone treatment from baseline. Same is the case with the quality of life and the days of sick leave basically. This is one of the studies I've shown that the patients who are on growth hormone treatment, they have a less sick leaves compared to those who have growth hormone treatment or a deficiency basically. Same is the case, the quality of life. A potential effect on cardiovascular health. A lot of risk factors causes hyperlipidemia, high insulin resistance, metabolic syndrome. But if the patient has been given growth hormone, actually they tend to reduce metabolic syndrome, improve the lipid parameters, and improve the cardiovascular other markers, actually CV markers, and in terms reduces the CV risk as well. But this aspect needs a long-term further studies to prove basically whether this is really beneficial in terms of cardiovascular health or not. This is a nice recommendation. In England, we actually were using one of the professors told me to study this score basically. This is a quality of life score. There are a lot of scores to measure the performance of growth hormone, but this is been used commonly in UK. It's basically Galen research developed a quality of life assessment of growth hormone deficiency in adults basically, in recognition to the lack of adequate outcome measures to assess the impact of growth hormone deficiency in the treatment of life basically. It's a very reliable, responsive questionnaire, and it's available in various languages. Unfortunately, not available in Urdu language, but it's available in various languages. Few minutes more, thank you. So the total number score is 25 item questionnaire, and usually lesser the score, good the quality of life. Higher the score, poor the quality of life. So treatment, you start the treatment, reassess the patient after 9 months, 6 to 9 months, and then reassess their quality of life on this score basically. If the patient has an improvement less than 7 points, there is no benefit of treatment, and growth hormone should be discontinued basically. Treatment basically, you start with a low dose in elderly patient, and younger patient you can start with a high dose, especially 0.2 to 0.3 unit per milligram per day. And how would you monitor? Basically, you need to keep the IGF-1 between -2 to 2 standard deviation, and keep in mind the assays been used, especially the IGF-1 ones. And you have several metabolic parameters you need to monitor, especially body composition, BMIs, DEXA scans, other CV parameters, lipids, waist circumference, glucose metabolism, and serum IGF-1 basically, and assess the adequacy of the patient is taking other pituitary hormones or not. DEXA scan measurement, and the complication of growth hormone, I'm not going to detail because of lack of time. Some adverse effects, especially insulin antagonizing effects, and some effects regarding edema, arthralgias, myalgia, hyperglycemia, and worsening of sleep apnea as well, and some sodium retention and water retention properties of growth hormone as well. And some risks involved in terms of cell proliferation, growth, and risk of de novo neoplasias. You can see over here, cancer, no increased cancer risk, no increased mortality risk. Cardiovascular benefits are there, basically need some further studies. In terms of cancer, if the patient has an active cancer, should be avoided. Once the cancer is stabilized, especially more than 5 years, you can then consider with the discussion with oncologist to restart growth hormone or not, basically. Patient having active diabetic retinopathy should be contraindicated, should not be used, basically. And all those patients who are diabetic, having glucose intolerance, they should have good diabetes control before starting growth hormone deficiency treatment. This is the long-acting treatment that has been approved by FDA, somatostatin, basically once weekly. Possibly Novo is planning to bring this drug in Pakistan as well, possibly next year. And difference between a daily version or a longer acting version, more or less height increase is more or less same. BMI, IGF-1 changes, glycemic changes, glucose changes, bone changes, more or less same compared to daily somatotropin versus weekly growth hormone basically. So summary, just last slide. If you have a high index of suspicion of growth hormone, if you have a high index of suspicion, you don't need to test each and every patient. If you have a high index of suspicion and the patient is willing to treat, willing to get growth hormone, then you go for a test basically. You have a test, growth hormone, IGF-1, and a glucose growth hormone stimulation test. And once after the test, you have confirmed the growth hormone deficiency, then select the appropriate growth hormone dose. Start with a lower dose in an elderly patient, those having a cardiovascular disease, and then review the patient after 2 to 3 months. Keep their IGF-1 level between -2 to +2 standard deviation, avoid going higher. And once stabilized, you then review the patient after 6 to 12 months and monitor their side effects, especially monitor their HbA1c, BMI, lipids, waist circumference, free T4, HP excesses, and the quality of life. That's the quality of life. There's the EXA score. And if the EXA score is more than 7 points from the baseline, to continue to growth hormone treatment. If the score is lesser than the 7 points, you can offer the patient to stop the treatment. Why? Because of limited benefit. And once the patient is on growth hormone treatment, you can have an yearly follow-up regarding their status, quality of life, and other parameters I've shown you earlier. Thank you so much.
Thank you, Sama. So our next speaker is Dr. Fahimullah from RMI, and he will talk about metabolic dysfunction associated steatotic liver disease, used to call NASH.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everyone. So I'm very thankful to Pakistan Endocrine Society for inviting me here, and especially Dr. Tahir, who has given me the opportunity to be here, and Dr. Fawad, who has spared us few extra minutes so we can take it. To be very honest, it's quite ironic and astonishing for an endocrinologist to talk about liver, because we have, and to be honest, we have come a long way. In endocrine, we used to talk about glycemic control, then shift from the glycemic control to the cardiometabolic health, and then cardiometabolic renal health, and later on, now we are talking about the liver as well. My job is to specifically talk about the emerging data. I will be discussing the trials that have been published, the trials that are upcoming, and I will not be going into the detail of the mechanism of action, how they are doing it, and don't ask me that because I don't know myself how it's happening. So we'll discuss with a few basic concepts. Okay, it's something. We'll discuss with few basic concepts. The things have changed from the past. The NFLD and the NASH, the words that has been replaced by the new classification and the new words called MSLD and MASH. And we will be discussing this MSLD and MASH. And by MSLD, we mean that fatty liver with metabolic dysfunction, and MASH is defined as MSLD with inflammation plus injury. So these are the new terminologies. Most of the trials that I will be discussing were started before these terminologies were introduced. So they still are named like NASH and things like that. But now the terminologies have changed and we're talking about the MASH and MSLD. So we define metabolic dysfunction associated with steatohepatite, hepatic liver disease, MSLD, by the presence of hepatic steatosis, which is 5% of fat accumulation in the hepatocyte that can be detected by imaging, biochemical markers, and histology, an individual with one of the 5 metabolic risk factors or with type 2 diabetes in the absence of other specific causes of liver steatosis. The diagnostic criteria is even more simple. You just need to know that there is hepatic steatosis, which is detected by the imaging and biopsy, and we need metabolic dysfunction and any one of the following can be defined as metabolic dysfunction if you have a patient who is overweight or obese, patient with type 2 diabetes, or anyone with 2 or more than 2 of the following 5 risk factors, with increased waist circumference, with a high BP, with a triglyceride of more than 50, and HDL of less than 40, and pre-diabetes. So if you have a patient who has hepatic steatosis plus metabolic dysfunction, simple diabetes, we can label this patient as having MSLD. The MASH is a bit worse condition, which says that you should have a hepatic steatosis, liver inflammation, plus hepatobiliary injury that can be ballooning, and plus minus fibrosis in the setting of metabolic dysfunction. So MASH is the advanced form of MSLD. And when we are looking for the fact that what are the key diagnostic features, we need to know that some of the features that can be diagnosed with imaging and other techniques, but few need biopsy. So steatosis can be diagnosed with imaging, inflammation plus minus can be diagnosed with imaging, but for ballooning, degeneration, and fibrosis, we need to have a biopsy. So the question that is necessary for diagnosis for MASH that we need to have biopsy? The answer is most probably yes, but for MSLD, we don't need biopsy. It can be diagnosed just with a metabolic dysfunction and a simple imaging. As we speak here in my 2025, there is no FDA-approved drug for MSLD in specific, but we have a drug that has been approved for MASH, and we'll be discussing this in the next few minutes. Before we go further, I will just these 2 important concepts because I will be talking about again and again about phase 2 and phase 3 trials. And the difference we need to know that in phase 2 trials, which are a smaller trials, usually have smaller number of patients as compared to the phase 3 trial, which has a larger number of patients, and it is done basically for the confirmation of efficacy and for the standard care. Usually the long-term trials, usually they are randomized multicentric trials, they have a clinical endpoint, and the more importantly, these are the trials that are needed for the approval of a drug for any disease. So we may have a very good phase 2 trial, but unless and until that has been replicated in phase 3 trial, the approval bodies cannot just approve a drug for any condition. We will discuss the common drugs that are either available with us or maybe we will get them in future. And there are a list of drugs that are in process, but they are less familiar to us. So we'll start with the first one, the GLP receptor agonist, the semaglutide, among the emerging therapies. And it started basically with step 1 trial. And those who are in endocrine, they know that step trials were basically a series of trials that were conducted on 2.4 milligram of semaglutide for obesity. So the primary objective of STEP trial was not liver, but the primary objective of the STEP trial was percentage change in the body weight with 2.4 milligram of semaglutide. It was a phase 3 trials with almost 2,000 patients, but few of these patients underwent liver function test as well as MRI to look for the regression of the fat hepatic steatosis in this trial as well. So 140 patient among the 2,000 patient had MRI with proton density fat fraction, and it showed that this drug, semaglutide, though it was not the primary outcome, but showed 38% reduction in the liver fat, and patient with 30% or more than 30% fat reduction was 72%. Histologically and historically, we know that more than 30% fat reduction means that it is an histological resolution of MASH. So it indirectly suggests that this drug can lead to the histological resolution of the MASH with a trial that was designed mainly for obesity, not for the liver. ALT was done in all of these patients, and there was a reduction of ALT by 13 units. And reduction of ALT is basically used as a surrogate marker for the reduction of the liver injury as well. So it showed that this drug may be leading to the reduction of inflammation and hepatic steatosis as well as to the resolution of the MASH. And this led to the phase 2 trial, which was specifically designed for the liver. So they took almost 320 adults with biopsy-confirmed NASH with a fibrosis from F1 to F3. In this trial, instead of normal semaglutide that we inject once weekly, remaglutide was injected once daily. And after the 72 weeks of study, it was found that almost 59% of the patient, there was MASH resolution with a fibrosis improvement that was more than or equal to one stage improvement, and no worsening of the MASH were observed in 43% of the patient, and more than 2-point reduction in this scoring that is done for the liver fibrosis is reduced by 71%, and obviously there was a massive weight loss that was a part and parcel of almost every semaglutide trial which was done with 2.4 milligram. That led to another trial, because you need to have a phase 3 trial for the FDA approval, the Essence trial, which is still going on. It is a long trial with a 240 weeks duration, but the first 72 weeks have been completed, and they have published the interim analysis, and which showed that there is a massive improvement in the MASH without worsening of the fibrosis in almost 63% of the patient. There was an improvement in the fibrosis in 37% of the patient, and both resolution and fibrosis improvement was seen in 32% of the patient. The ALT, AST, and gamma GT were reduced in all of the patients. There was improvement in the fat fibrosis scoring as well, and the lipid stiffness as well. And just over the time, it's most probably just a matter of fact, a matter of time, once this trial is completed and published, we will get approval for semaglutide in the MASH patient as well. So semaglutide has a very good data in the phase 2 trial. We have a strep trial to support this one. Liraglutide has the same data with a lean trial, but if you look at the MASH resolution, that was 60% almost with semaglutide and almost 39% or 40% with liraglutide. Dulaglutide has a data, but that is just with the reduction of ALT and not any histological improvement. So moving on to our second drug, that is basically tirzepatide, which is dual GLP-1 and GLP-1 receptor agonist. And again, the story started with the SURPASS-3 study, and those who are endocrine, they know the SURPASS studies were basically done for the HbA1c reduction of tirzepatide. So the primary aim was to compare tirzepatide with insulin degludec, but there was a subset of patients who had this MRI done, and liver biomarkers were also measured in this patient. And this liver function, these markers were studied in 296 patients among the 2,000 patients of the SURPASS-3 study. It is a long phase 3 trial, and it showed that with the maximum dose of tirzepatide, reduction in the liver fat was seen in almost 50% of the patient. Almost more than 30% improvement in the fat reduction was seen in 82% of the patient, and achieving of less than 5% fat, that means resolution of the hepatic fatty liver was seen in almost 66% of the patient. The same results were replicated by the SURMOUNT-1 trial, which was again done by tirzepatide for obesity without diabetes. So SURMOUNT series is on tirzepatide for obesity, and the SURPASS series is on tirzepatide for diabetes. Both of them showed, and again over here, the main purpose was to evaluate the tirzepatide in body mass reduction, but they also looked for the ALT reduction in this patient as well. And it was found that the more weight is reduced, the more ALT reduction is done, and we have discussed previously that the reduction of ALT is directly related to the reduction of the inflammation in the liver. So again, once it did show that a drug is so good for the liver, phase 2 trial on tirzepatide was conducted, and it's a small trial of almost 12 to 26 weeks. All the 3 doses, 5, 10, and 15 milligram of tirzepatide was compared, and it was shown that almost 30 to 50% reduction of liver fat was seen. There was improvement in the ALT and AST. There was a meaningful weight loss, as we know that tirzepatide is the most powerful drug available for the weight loss. And this led to another trial that is called Synergy NASH trial, which is the phase 3 trial for the tirzepatide. And here, the basic primary objective was to look for the MASH resolution without the worsening of fibrosis and improvement of more than or equal to 1-stage improvement in the liver fibrosis. They took patient with F1 to F3 fibrosis, excluded the patient with F4 fibrosis, that is cirrhosis, and this trial was necessary because, as we mentioned earlier, that we need to have a positive phase 3 trial to go for approval. And again, it was shown that the maximum dose of tirzepatide, there was almost 62% reduction with the MASH resolution without fibrosis. There was 51% reduction in the improvement in more than 1-stage fibrosis. There was a massive weight loss in this drug as well. So this is the data for the tirzepatide, which started with the SURPASS-3 trial, then SURMOUNT trial, which were phase 3 trials, then tirzepatide phase 2 trial, and now the Synergy-3 phase 3 trial. And most probably we'll be expecting the approval of this drug for the MASH at the end of this year, or most probably next year. The other group of drug that is SGLT2 inhibitors, empagliflozin and dapagliflozin. There are trials on empagliflozin. There are small trials. Usually they have a very small sample size, are 40 to 50 patients. They have MSLD with diabetes, without diabetes. They have checked for MRI, PDDF, and there is a fibrosis score as well. And to summarize all these trials for you, that there was a fat reduction was seen, which was significant liver fat reduction, and there was a reduction in the ALT, and there was a small weight loss as well. So the key finding in the empagliflozin trial that there was associated fat reduction, there was a reduction in ALT in all patients, and there was fibrosis reduction was seen in only one study, because only one study did the elastography. None of the other study did the elastography, and there was associated weight loss as well. For dapagliflozin, we have a meta-analysis of 5 trials with a very few number of patients. They were small trials, and all of the conclusions suggest that dapagliflozin improves liver inflammation, glycemia, and hyperglycemia in weight loss. One of the important trials that has been recently published, not published yet, but the data has been is there, that their primary endpoint, this was the first of its kind phase 2 trial on dapagliflozin, where they look for the improvement of the liver histology. And again, it showed that the liver enzymes were improved, the liver fat content were improved, and there was mild improvement in the liver fat as well. So for dapagliflozin, there was the Dean study said that there is significant improvement in the NASH was observed. There is improvement in the ALT and AST, and there was improvement in the liver fat content as well. The last drug that is being now available in Pakistan that has been shown that this drug works better, that is selective thyroid hormone receptor, that is THR beta agonist resmetirom, which has gone through the phase 2 and the phase 3 trial. Started with the phase 2 trial with a small trial of 36 weeks, 125 adults were biopsy confirmed, NASH were included, and it showed that using this trial, this drug, there was 32.9% fat reduction by 12 weeks. There was 37% reduction by 37 weeks. The ALT was significantly reduced. There were very great improvement with LDL and the rest of the lipid factors as well. Maybe we will be seeing this drug for the lipid lowering in the days to come as well. But this trial was followed by phase 3 trial, which is called as Mestero-NASH trial, which was a 52 weeks trial with almost 1,000 patients. They were given oral mesterone, resmetirom for 80 to 100 milligram, and they observed that there was NASH resolution without worsening of fibrosis within 30% and improvement of fibrosis in 25% of the patient. There was reduction in the lipids, AST, ALT, and there was improvement in the liver elastic stiffness as well. And based off this trial, resmetirom is the first drug that has approved by FDA in March 2014 for the treatment of MASH, but not for MSLD. To summarize what I have said till now, we have the strongest evidence for resmetirom, which has been approved on the basis of the phase 3 trial and is the only drug that has already been improved. We have a very massive data on semaglutide, and with the phase 3 trial, Essence trial, which is ongoing, will be reported later, maybe from 2 years from now in 2027, and it's most likelihood that this drug will also get approval for the MASH. Tirzepatide, the MASH Synergy 3 trial have been completed. The data is there, and most probably this drug is gonna get approval for the treatment of MASH in this year or maybe next year. And we have a small data for dapagliflozin and for empagliflozin, but the data is not that robust. They don't have phase 3 trial, so most probably we will not be seeing these drugs improved for the treatment of NASH in the MASH in the upcoming days. This is the last slide. There's a lot of data coming up, so there are many other drugs. The top of the list is retatrutide, which is a triple agonist. The triple agonist that is coming with a GLP-1 agonist, GIP agonist, and glucagon agonist. And the phase 2 trial has been completed. The phase 3 trial has been planned, and most probably in years to come, this drug will receive approval for the treatment of MASH as well. We have survodutide, that is a dual GLP-1 glucagon receptor agonist. The phase 2 trial MASH has been completed. The phase 3 trial has been planned, and most probably this drug will be upcoming year will be on the board for the approval for MASH. We have which is linifepranol, which is pan PPAR agonist, and there is a phase 3 trial going on. The NATIVE 2 trial have shown positive result. The NATIVE 3 trial has been ongoing, and most probably this drug will receive approval as well. And there are many other Armacol and their obeticholic acid. They are the drugs that the last one has a very good effect on the phase 3 trial, but there were associated pruritus and high ALD. It was effect on the lipids, so most probably this drug has been withdrawn and it will not be receiving any approval. But there are data that is coming in a bundle, but the drugs that we are using these days, semaglutide, maybe tirzepatide in the upcoming days, and resmetirom, that these are the drugs that can be used in the future for this condition. Thank you so much.
Thank you very much. Our next speaker is Dr. Sabine Zia. She's from IRNM. She's going to talk about beyond the scalpel, what's next in nuclear medicine for post-surgical thyroid carcinoma patients.
Assalamu alaikum everyone. I'd like to thank Dr. Tahir for inviting me here. And my focus today will be on the post-surgical management of differentiated thyroid carcinomas. However, it is crucial to understand that surgical resection remains the cornerstone and primary treatment modality for management of thyroid carcinomas. Thyroid cancer is one of the most common endocrine malignancies with a rapidly increasing worldwide presence. Limited data is available on thyroid cancer in Pakistan. In Pakistan, it is more prevalent in females than males and has an incidence rate of 1.2 to 2%. With initial surgery often achieving initial disease control, the question becomes, what's next? This is where nuclear medicine steps in, providing crucial insights into the microscopic disease, guiding adjuvant therapy decisions, and enabling vigilant follow-up to ensure the best possible long-term outcomes for our patients. To understand the impact of nuclear medicine on management of thyroid carcinomas, I'd like to give you an example of one of my patients. This 25-year-old female Afghan patient presented following total thyroidectomy in November of 2019. Histopathology showed follicular variant of papillary thyroid carcinoma. The tumor dimension was 4 centimeter. It had capsular invasion, but there was no lymphovascular invasion or any extrathyroidal extension. At 6 weeks post-op, she had a baseline TSH of 37, thyroglobulin was valid and it was 210. I131 whole body scan showed residual disease or thyroid tissue in the neck and there were no distant metastases. As per ATA 2015 risk stratification, she was placed in the low risk group. She received 100 millicurie of radioactive iodine 131 in January of 2020. Then she was lost to follow-up. However, she kept taking thyroxine. She came back for another follow-up in September of 2024. At that time, she had a stimulated and valid thyroglobulin of 536. I131 whole body scan of September showed metastatic disease. Here, if you can appreciate, the focus that you see at the top of this image, it is in her right parietal bone, and you can appreciate this focus in the SPECT CT images on the right of this page. The focus below that is in the neck of that patient, and the multiple dots that are on both sides are in bilateral lungs. So now, do you think that she is still in the low risk category? I don't think so. Let's move forward. So even after adequate surgery with seemingly favorable initial findings, we can clearly see that the long-term management of differentiated thyroid carcinoma is guided by a crucial process called risk stratification. It involves carefully evaluating various factors identified before surgery, during surgery and pathology, such as tumor size, spread, characteristics of tumor cells, risk of recurrence, and response to initial therapy. Risk stratification is a dynamic, iterative process that begins as soon as a suspicious nodule is detected and continues through the final follow-up. From a practical standpoint, post-operatively, we use the AJCC or the TNM staging system to predict the disease-specific mortality and the ATA risk stratification system to predict the risk of recurrent or persistent disease. ATA divides these patients into 3 main groups. The low-risk group, the patients that are included in this group are those who have their tumor confined only to the thyroid gland. It is 4 centimeter or smaller in size. There is no aggressive histology. There may be some micrometastasis, but there is no vascular invasion. It could be a NIFTP, a papillary thyroid carcinoma, or a follicular thyroid carcinoma. The patients in intermediate risk group have a 6 to 20% chance of persistent or recurrent disease, and these are the patients who have an aggressive variant of the disease. The tumor has grown through the thyroid gland into the surrounding tissues. There may be more than 5 lymph nodes involved. There may be invasion of the vessels. The high-risk group patients are those who have a more than 20% chance of persistent or recurrent disease. These patients often present with advanced locoregional disease. They have extensive lymph node involvement, and some of these patients even present with distant metastasis, and there may be incomplete resection of the tumor. So in nuclear medicine departments, patients present after a lobectomy or a thyroidectomy with no lymph node sampling or a thyroidectomy with neck dissection. So if a patient presents post-lobectomy, then an ultrasound of the neck should be performed to see for the status of the other lobe as well as cervical lymph nodes. If there are any suspicious areas, those areas should be biopsied. If there is gross positive resection margin, or there is gross extrathyroidal extension, or there is more than 1 centimeter size of that primary tumor, or there is a poorly differentiated histology, ideally these patients should undergo completion of thyroidectomy as well as therapeutic neck dissection. However, if the patients have a microcarcinoma, there are negative resection margins, there is no contralateral lesion or suspicious lymph nodes, then these patients can be kept on disease monitoring or active surveillance. ATA 2015 tells us that preoperative risk stratification is needed. However, total thyroidectomy remains the treatment of choice for low-risk 1 to 4 centimeter papillary thyroid carcinomas. If the patient is planned for radioactive iodine therapy anytime during the course of treatment, total thyroidectomy must be performed. So if a patient presents after surgery, a thyroidectomy with or without neck dissection, and there is no gross residual disease in the neck, then we can plan the patient for radioactive iodine 131 therapy. If there is gross residual disease in the neck and it is resectable, then you should send the patient for a surgery. If surgery is not possible, then 6 weeks post that first surgery, patients should get their TSH, TG, anti-TG levels checked along with I123 or I131 whole body scan. If there is radioactive iodine avid disease, then the patients can be planned for, and there are no compression symptoms, then the patients can be planned for radioactive iodine 131 therapy, followed by TSH suppression with thyroxine. If there are any metastatic foci, for example, there is a focus in the spine or any of the bones, that area, and you have a suspicion that that area might get fractured in the future, then ideally that patient should receive external beam radiotherapy for that area. Radioactive iodine 131 therapy can be kept on hold in patients who have a tumor less than 2 centimeter in size. It is intrathyroidal, it may be unifocal, it may be very small in size, and the postoperative unstimulated TG is less than 1. However, if the tumor size is more than 2 centimeter, there is cervical lymph node involvement, there may be vascular invasion, there may be distant metastasis, all these patients should get radioactive iodine 131 in large doses. The indications for radioactive iodine 131 are almost similar for papillary, follicular carcinomas, oncocytic carcinomas, and even poorly differentiated carcinomas if they are radioactive iodine 131 avid. I recently came across this study and it was published in the Journal of Nuclear Medicine a couple of months back. In this, they studied the impact of radioactive iodine treatment on long-term relative survival in patients with papillary and follicular thyroid carcinoma. And they concluded that depending upon the histologic subtype, the relative 10-year survival rate is higher in patients with low, intermediate, and high-risk differentiated thyroid carcinoma after undergoing radioactive iodine 131 therapy. For follicular carcinomas, a clear trend towards higher survival rate was observed even for low-risk, minimally invasive follicular carcinomas. And for papillary carcinomas, a survival benefit prevails in the presence of lymph node involvement and larger tumor size and is more pronounced with distant metastasis. Following radioactive iodine 131 ablation dose, patients with aggressive or metastatic disease have their first disease-specific follow-up at 6 months post-radioactive iodine 131, as per the AJCC guidelines. Generally, patients in low or intermediate risk group get their follow-up investigations at 10 to 12 months post-radioactive iodine 131 therapy. Follow-up investigations include stimulated TG, anti-TG levels, neck ultrasound, and a I123 or I131 whole body scan. Initially, these investigations are performed on yearly basis, and if everything stays good and the patient remains disease-free, later the frequency of whole body scans is reduced. However, stimulated or unstimulated TG, anti-TG levels, and neck ultrasound are repeated once every 10 to 12 months for a very long time. If there is recurrent or persistent disease, and that disease is radioactive iodine 131 and avid, then these patients should be evaluated for any possible surgery. If surgery is possible, get your patient that surgery. Do the histopathology and give them radioactive iodine 131. If surgery is not possible or it is not needed because the tumor is really very small, then you can give another dose of radioactive iodine 131 and do a post-therapy scan to see if the medicine actually went to those diseased areas. If the patient has a recurrent radioactive iodine 131 refractory disease, then your patient should get a contrast-enhanced CT or an MRI with contrast or a PET scan to see for any physical evidence of disease. If surgery is possible, again, surgery followed by histopathology should be done. If not, then careful watch should be carried out if the disease appears to have an indolent course. Tyrosine kinase inhibitors or systemic therapy should be thought about, and it can be given in progressive disease. By now, I think we all know the algorithm for management of differentiated thyroid carcinoma, so I won't go into much detail. So if a patient has a known structural or residual carcinoma, or the patient is at high risk for recurrence, then TSH level should be maintained below 0.1. If the patient is disease-free for years and there is low risk of recurrence, then TSH can be kept within normal range. For patients at low risk of recurrence with biochemical evidence but no structural evidence of disease, the TSH level can be maintained between 0.1 to 0.5. NCCN guidelines also tell us that patients who are on chronic TSH suppression, they should be supplemented with daily calcium and vitamin D. Following total thyroidectomy plus radioactive iodine 131 remnant ablation, stimulated and valid thyroglobulin of less than 1 is highly predictive of an excellent response to therapy. Another carcinoma that needs surgery is the medullary thyroid carcinoma. In nuclear medicine departments, we generally do not treat medullary carcinomas or anaplastic carcinomas, so I'll just give you a brief overview of these two. Following surgery, the patient should get CEA and calcitonin levels checked. There should be screening for germline mutations. EBRT or external beam radiotherapy is generally not indicated. TSH normalization is needed after surgery, and nuclear medicine can help you with different kinds of imaging. There is role of tyrosine kinase inhibitors in progressive disease. Anaplastic carcinomas, as we all know, it is stage 4 at the time of diagnosis. Therefore, clear discussion regarding expectations, management, prognosis, and palliative care are really very important, especially for airway management. Surgery should be opted if needed and possible. Oncology consultations regarding chemotherapy, radiotherapy, and targeted therapy should be done. TSH normalization is needed after thyroidectomy, and best supportive care is needed for each and every patient with anaplastic thyroid carcinoma. Thyroid lymphomas are beyond the scope of this presentation, so I won't go into details. So I'd like to show you a good slide about the patient that we discussed earlier. So we remember that she was lost to follow-up, and then she presented with a raised thyroglobulin of 536, and she had a metastatic disease on I-131 whole body scan. She received 200 millicurie of radioactive iodine 131 in September of 2024, and then I followed her up in April 2025, and the scan on the left side of this image that you see here was performed on 30th of April. She is disease-free at the moment. Her thyroglobulin is 0.7, it is valid, and there are no abnormal foci in her parietal bone or neck or in lungs. The hazy uptake in this center of this page that you see is the normal radiotracer accumulation in the gut and the urinary bladder. So taking advantage of this opportunity given as Publication Secretary of Pakistan Society of Nuclear Medicine, I'd like to invite you all to join us for the 10th Annual Conference of Pakistan Society of Nuclear Medicine. This year's conference will be in Lahore from 31st October to 2nd of November, and the last date for abstract submission is 7th of September 2025. Thank you so much for your patient listening.
Thank you very much. I have a few questions sent to us by our audience. One of them is by Dr. Sardar Ali Khan. This is for Dr. Fuad. As for refractory TART, sperm cryopreservation is advised. Which female patient with congenital adrenal hyperplasia requires counseling for oocyte cryopreservation?
सर काइंडली दोबारा बोल देंगे ज़रा कुछ लंबा सवाल था उर्दू में
For females, which females with congenital adrenal hyperplasia are advised cryopreservation of their oocytes?
Sir, most common CH is 21 alpha hydroxylase deficiency जो severe viralized females होती हैं उनके अंदर ovarian adrenal rest tumors ज़्यादा होता है तो उसके लिए cryopreservation होती है. Egg preservation basically उनके लिए offer की जाती है. Ovarian tumors are less likely to occur as compared to TART. तो ओवेरियन का डाटा भी काफ़ी लिमिटेड मिला है लेकिन ऑब्वियसली उसके लिए जो CH severe 21 हाइड्रोक्सिलेज हो उनके अंदर रिकमेंडेड है कि एग प्रिजर्वेशन करवा लें वो बिफोर डेवलपमेंट एंड ऑन ट्रीटमेंट.
Thank you.
अगला भी मेरा ही होगा ज़ाहिर बाकी तीनों तो बहुत मुश्किल
I
टॉपिक.
can ask a question. Role of steroid in non-classical CAS.
Excellent question. In terms of fertility only, there is a divided opinion. You start off with all the other factors like anti-androgens, if the patient cannot get fertile, you can give lower doses of steroids in the same manner as of conventional CH.
For Dr. Osama, what to expect for other hormone replacement doses, that is levothyroxine and glucocorticoid, if someone is started on adult growth hormone replacement, would those doses change if patient is taking growth hormone?
Yeah, before starting growth hormone, you need to optimize the doses. And once you start growth hormone, there's mild changes in the steroids as well as thyroxine doses, basically. Steroid dose tend to, I think, slightly increase, basically. Otherwise, there are mild changes in thyroxine because actually the growth hormone improves the conversion of T4 to T3 in the peripheral tissues, actually.
Acha ji. That's the question for, is there is a role of pioglitazone and vitamin E for MASH? Fahim.
Assalamu alaikum. So, as my topic was to look for the emerging data, so these were the slides that were for emerging data. People use it, but there is no documented role that has been approved, or these drugs are supposed to be given for the MASH. We are giving these drugs in the hope that there will be improvement. लेकिन कोई data ऐसा नहीं है. There is no recommendation, any guideline recommendation नहीं है to give pioglitazone or metformin or vitamin E for the improvement of this condition. So there is no guideline data on this.
Thank you. For Dr. Sabeen, when do we label disease as radioactive iodine non-avid? After what kind of radioactive iodine dose if post RAI scan is negative? And can we use any pharmacological agent to increase the uptake of iodine in that particular tissue, in suspected tissues?
Actually, I think your question has two parts at least. The first thing is that when we label a case as radioactive iodine 131 refractory means it means that when we do the I131 or I123 whole body scan, these are the radiopharmaceuticals, and the tumor does not take either of the radiopharmaceuticals, then we can label it as refractory disease. Or if the disease progresses on routine management that we give, or if in any case it is not taking up any medicine and it is not responding to the treatment, and even there are some patients who present with radioactive iodine refractory disease after surgery. So in those patients, some people have tried giving lithium. What we do is that we try to image those patients with other radiopharmaceuticals like MEB, because MEB is also a non-specific tumor imaging agent, or we do a PET CT scan, and then we can see if there is any disease. Generally, these patients have a poorer prognosis. Their disease progresses really fast. In these patients, we can give tyrosine kinase inhibitors. Currently, what we are giving is lenvatinib. But what I have seen with my patients is that the response to lenvatinib is not really very good, because patients generally do not tolerate the actual dose which is needed for the treatment. The dose that is needed is 4 milligram OD, but my patients have been able to hardly tolerate 8 milligram or 4 milligram per day. So it is not working that much in those patients. So we keep that thing only for few patients. Have I answered your question?
I guess so.
Okay, for Dr. Sabeen.
This is the last question of this session, and after that we'll conclude.
Dr. Sabeen, in your experience, for low-risk thyroid cancer, you presented a case as well. Do you routinely give them radioactive iodine?
Yes, sir. We do give them radioactive iodine 131, and this has been proven from the study that I showed you. It was published in the Journal of Nuclear Medicine, and it is a high-impact journal. You can check it yourself. There is good impact of radioactive iodine 131 even in low-risk patients and low-risk minimally invasive follicular carcinomas or papillary carcinomas. Because this was a low-risk case that I discussed, that she was lost to follow-up. She was taking thyroxine despite that radioactive iodine 131 that was given initially, and she presented with a recurrent disease. And she is still in the high-risk group. So I'd like to follow her up closely. So we do give.
Because in low risk, you can get microscopic, you could get 1 to 2
Yes.
centimeter.
No, sir, the thing is that in papillary carcinomas, they tend to have micrometastasis. So we generally don't see those things on scans. So if there is any suspicion, we do give them radioactive iodine-131.
Because we are collecting a data, so soon we will have a data on it. We got about 100 patients with low risk with 1 to 3 centimeter, and we found actually there was only one case of recurrence. But I think in the future we will have more data on this.
Sir, the thing is that in those patients, active surveillance is needed.
Yeah.
What you can see in that patient, she is an Afghan patient, but she lives in Pakistan. And even then, she was lost to follow up. Despite giving that radioactive iodine-131 initially, she was lost to follow up. And it's really hard to manage such patients. So we are left with only few choices. So we prefer to give them radioactive iodine that at least they do not have a chance of recurrence. But like you see in that study, and you can see many studies in various journals, and they have been looking at this thing specifically, that if radioactive iodine-131 is going to benefit some of the patients. In some patients, we have kept radioactive iodine-131 on hold. I do have some patients. But in most of the cases, we prefer to give them radioiodine.
Thank you very much, all the speakers, for excellent talks. And regarding congenital adrenal hyperplasia, just 1 or 2 points I will highlight. Do not ignore the sexual dysfunction of the female when it comes to infertility. Many times we are busy addressing the organic causes, but sometimes there's a psychological trauma on that female, having gone through surgery, having painful intercourse. So that certainly needs to be addressed. And sometimes patients with non-classical heterozygous type can just mimic like a polycystic ovarian syndrome patient. So that's another important point. All the PCOS, you need to be careful before labeling them PCOS. Make sure it's not one of those cases of non-classical heterozygous, mild case of congenital adrenal hyperplasia. Growth hormone presentation, very well done by Dr. Osama. And for me, the take home message for you guys is growth hormone is something we should not be started very lightly in adults. There has to be a very strong reason. It should not be given just based on symptoms. Just like Dr. Osama highlighted, there has to be really an organic dysfunction of the pituitary gland or a childhood deficiency which needs to be retested, reevaluated, and to be given. Thirdly, very good talk from Dr. Fahimullah regarding MASLD. That's a lot of new drugs are in the pipeline, but as of we know, most of the drugs, they help you lose weight. So lifestyle changes still continue to be the cornerstone of this disease. And now there are multiple agents, some already approved and some in the pipeline. They are there to help with this problem. As a matter of fact, in the developed world, the biggest cause for cirrhosis is MASLD is a non-infectious cause rather than the infectious cause at this point. And coming to the last part of the presentation regarding nuclear medicine for our differentiated thyroid carcinoma patient, I think again in this key is the follow-up on those patients. Different centers can have slightly differing protocols. I may not agree with one center because I tend to go with Dr. Waqas said that in a low-risk patient, maybe this patient does not need a radioactive iodine ablation. But even if but in all these cases, with the thyroid carcinoma, especially the differentiated carcinomas, which have curable disease, the key is a very close follow-up and good counseling of the patient so the patient can keep coming back to their physician for re-evaluation and further interventions as needed. Thank you, Dr. Waqas.
Thank you. I think all talks were brilliant. They were excellent. Thyroid cancer is very close to me, so I will just add a comment on it. It's good that this time we have added thyroid cancer in the endocrine meeting, and I think that's something which we need to add more and more because it's actually quite common cancer. And the good thing about it, it got an excellent prognosis. Very rarely people die from thyroid cancer. So it's an excellent prognosis. And important part is, as Dr. Khurshid mentioned, is the follow-up. And the guidelines are changing every day. and in future we probably will be treating them much less severely as compared to what we are doing now. Before 2015, everyone was getting treatment quite aggressively, but as the evidence is coming, now the treatment is getting less and less, and it's good that the treatment is now less intensive in low risk. So that's my message for this talk. Thank you. And I think with this, we will conclude the session.
And move to the next
Move
section.
to the next.
Thank you.
Whether you are a